I am very, very honored to introduce Dr. Roland Thorpe. You've heard his name repeatedly this morning. Just to give you a brief background, he is a gerontologist and social epidemiologist with nationally recognized expertise in minority aging, men's health, and place-based disparities. He is a professor in the Department of Health, Health Behavior, and Society in the Bloomberg School of Public Health at Johns Hopkins. He's a social epidemiologist, and his research focuses on race, socioeconomic status, and segregation influence in health and well-being for African Americans, particularly for African American men. So I know he has a word for us. Dr. Thorpe.
Good morning. Nope, stop. Let's do this again. Let me give you a little background that she left out. I'm from Macon, Georgia. I'm from the South. I come from a long line of Baptist preachers, of which I'm not, but I do believe in call and response. So let's try it one more time. Good morning. Good morning. Oh, I feel the love now. So welcome. So first of all, I just want to say thank you to the organizers of this conference. It's a very important, timely, and significant topic to be engaged in discourse in. And I'm very honored and humbled to be here today to learn from, in a community around this area. So before I start today, I want to just share with you real quickly. I'm going to go ahead and address the first comment that I thought I'd hold off. Gerontology is sexy. So I'm just going to let you know, it's sexy. And when we get to the end, we can have some more conversations. We talk about it, and we can talk about it over lunch. But I want to spend the next 35, 40 minutes sharing with you how I got into Black men's health and how I got into starting to think about Black men's brain health. And then from there, where I think some of the approaches I think we need to take up to advance this field. Next slide, please. Next slide. So before I start, next slide, please. Before I start, I want to socialize Black men's health as a social problem, right? Oftentimes we see it and hear it as a health problem, but I view Black men's health as a health problem and a social problem. And I'm reminded of the book that I'm reminded of when I think about it as a social problem. It's The Invisible Man by Paul Ellington. I as an undergraduate at Florida A&M University, I came across this book in the mid-90s. And I think there's a whole 2 pages that really resonate with me, but I only have up on the screen this paragraph that really resonates with me. And for all the emerging scholars that are here or online, let me tell you real quick, you got to find something that's going to motivate you, because there are going to be good days and there are going to be bad days in this business. But the key is that your good days outweigh your bad days in this business. And we need to think through and think about how those are. I think about The Invisible Man, and I think about this quote here. And it says, I'm only going to read the first line. I'm invisible, understand simply because people refuse to see me. Now I'm going to have a pregnant pause because I want y'all to think about what's been going on since 52 to 2020. And all of the Black men that we've lost along, and women that we've lost along the way, and think about why we lost them. And I contend to you in the book, this is a young man that describes how he's encountering and engaging America at that time. And I contend to you as a social problem, a lot of those problems are still relevant today. Next slide, please. So this is a picture of a graph of how I actually got into Black men's health. I was given a lecture to an undergraduate course on cultural factors. And I had this slide just to show that there are differences in life expectancy by race, sex groups. And what struck me is that ever since the data has been collected, we see Black men have the lower life expectancy. And then I asked the question from that, I started to ask the question as to why. Clearly there has to be an answer. Well, this was, I think, in 2010. So clearly there has to be an answer. And what I found when I was doing this, there was no answer. And so I decided to take up this idea around Black men's health and try to answer just the question of why this exists. Next slide, please. And in doing so, I started to learn more, and I understood, in addition to having those lowest life expectancy, it made sense to me that we also have these higher proportionate of chronic conditions and premature deaths, as well as these higher levels of illnesses. And so this population as a whole is characterized as we as Black men, we literally live sicker and die younger than anyone else, than many of our groups. And so I was blown away. I was blown away by it, but then I went back to my socialization of understanding Black men's health. We're just hidden in plain sight. We're invisible, right? Next slide, please. So one of the things I started to do during my career at that time is I was still a part of the one of the specialized centers on health disparities, and I created this program for research on men's health so that I can address these issues. And I still run the program today. Next slide, please. And this is the mission of our program. It's an aggressive mission, but we still want to create knowledge, and not only just create knowledge for the sake of knowledge, create knowledge to develop health promoting strategies and policy relevant solutions. And we want to do that with regard to research, but also a huge component of that is training, and training the next generation of leaders in this area. Next slide, please. And so how we're organized, and we organize ourselves in the framework using the NIA Health Disparities Research Framework that Dr. Hill spoke about earlier today in his presentation. He's the lead author on the paper. And we use this framework to help guide all our thinking around that we should move beyond this siloed approach that we have in research, and think about the synergistic effects. And this framework affords us the opportunity to think about that and what happens from when you think about looking at how the environment impacts the social, cultural, behavioral, and then the biological areas. And think about, we no longer can afford to do work in just one of those silos. We have to work across those and gain an interdisciplinary team to have a synergistic effect, to think about how these factors operate on Black men's health and Black men's brain health. Next slide, please. So about 4 years ago, I was still working in the area of Black men's health. And about 4 years ago, myself and Dr. George Reeboks were fortunate enough to be one of 8 Alzheimer's disease focus centers, home resource centers for minority aging research. It's funded by NIA. A lot of that came from that, I guess, is it that $3.2 billion? Yeah, these centers came out of that $3.2 billion, and we're excited about it. One of the major components of this, of our RICMAR, next slide, please. One of the major components of our RICMAR at Hopkins is that we have a dedicated effort to mentoring, and that's one of the overall goals of RICMARs in general. And then our work focuses on this life course approach to ADRD research and to cognitive impairment. Next slide, please. So I want to just briefly talk about this so that we're all on the same sheet of music. When we think about dementia, dementia is this umbrella term. There are a number of, it's a broad category for brain diseases. So there are a number of different diseases, but what I'll be talking about largely today is the Alzheimer's disease and related dementias from here moving forward. Next slide, please. One of the things that I have found and thought about when we're talking about Black men's health, what I've thought about is how can I move the work from Black men's health to Black men brains health? How can I connect them? Because I've heard a lot of conversations this morning, but what I haven't heard, but I think it's in the air, and I'll just say it explicitly, we can't disconnect the two. We can't disconnect Black men's health from Black men brains health because of the known risk factors, right? So we can't do that. And so I think what I think we should do is think about, while it's important for us to think about these different areas and different types of health, but we need to take a holistic and comprehensive viewpoint, particularly when you're talking about getting Black men in a study, because you ain't gonna get us, and I said you ain't gonna get us too many times to participate. When you got us, you need to get the most, and then and we're gonna talk about what you need to do to keep them in the studies. So Dr. Hill went over this. We know that, and many of you know this in the room, that Alzheimer's disease is a huge public health problem. You know, with the major societal burden, we have over 5 million people who have it. 1 in 9 adults are 65 years or older, and then even about a third of our 85 years and older. and approximately 2/3 of them are women. Next slide. And in addition to that, we know that there's major disparities that needs to be addressed, and the reasons for these disparities are not quite understood. However, Dr. Hill talked about a number of different reasons that could help us better understand and address these disparities. Next slide. So one popular approach to addressing disparities in general, addressing the ADRD, is to think about addressing these social determinants of health. And that's an approach that has been used over the years. And I think it's a very reasonable approach. Next slide. And it's reasonable because when we think about factors that influence our health, most of them occur outside of the medical setting. About 80% of them occur, 80% of them are not occur in the medical setting. So thinking about social determinants of health are very important. Next slide. However, one thing that we haven't talked about and we have to talk about is that these social determinants of health are undergirded by racism. And until we think about dismantling racism and the structures and the spaces in which it occupy, I wonder how far advanced we could go. I just wonder that. And I think it has to, and I think we need to come to a reckoning, because I don't, maybe I'm biased because I'm a Black man, but I don't know any other group that has been impacted the way in which Black men have been impacted over the life course as it relates to structural racism, going back to when we thinking about the GI Bill from World War II, the differences in the GI Bill that impacts the building of wealth across the life course, to where we are now in a space, there's this wealth gap that we're trying to fill, where is policies that are in structures that were in place years ago that still impact us now. So when we think about these things, we need to think about how that we can address them, and think about, if we're not talking about racism in that conversation, then I think we need to change the conversation, because it sits at the center of the table, right? And we need to just deal with it and deal with it in a meaningful manner. And now we can't fix this overnight. I'm not going to give you any solutions to fix it overnight, but I think engaging in the conversation and start taking some steps now, we may be able to make this place a better place for maybe my great-grandchild, my great-grandchild. Next slide. So with regard to what we're doing with regard to racism, my colleague, Dr. Sarah Zanton, has been awarded by NIA, and I'm happy to be on her team. We're thinking about putting together a structural discrimination measure, and this measure differs than the ones that's currently in the literature, is that we're thinking about across different domains and how discrimination has affected people. So we're talking about civic sector, education sector, economic sector, just to name a few. And we're thinking about, we are going to put together this measure and then want to add this measure into current large scale studies, so we can then start being able to have a better understanding of how structural discrimination can impact health and well-being. Next slide. So now I want to turn my attention for the next couple of minutes to talk about some key approaches that I think that we need to take to move forward in brain health for Black men. One of the things I typically say when I give talks, and I'll say it here, one of the things I encourage all of us to do is join me in my new crusade. People, I know Dr. Hill's kind of nervous because he don't know what I would say. And I know Iris is nervous as well, but it's good. I'm gonna ask you all to join me in my new crusade. And my new crusade starting in 2022 is that when we talk about us, we talk about us from a strength-based approach. No longer are we talking about deficits. Can you join me in this crusade? Would you join me in this crusade? Thank you. And we need to think about it. So from now on, I think, and I'm gonna slip up now. So if I slip up, I want you to check me. All right, I definitely gonna slip up, but I want to think, instead of thinking about challenges and thinking about deficits, can we think about strengths, assets, and opportunities to engage? So I want to talk to you the next couple of minutes. I want to talk to you about some approaches that I think are opportunities for us to advance. I'm going to talk about 4 that's listed on here, and then I have one final one that I think, that I know would certainly resonate with you all. So the first one is this, next slide, this underrepresentation of Black men in clinical research. So this is just a picture of the number of males in the National Health and Nutrition Examination Survey. It's a large survey that's funded by the federal government, and they do it annually. And I just looked at the number of, I just took the 2018 data and I just looked at it and I rated across years, different age groups, age years. And then, so as you can see, when we think about, particularly when you look at the third column from the left, as I'm viewing it, is we see national non-Hispanic Black men. We see that their numbers are really low. And so what can we infer from that? We can't do much analysis to infer anything from that to create an evidence base to think about health promoting strategies. So we got to get more men in these studies, right? And this is a national study that oversamples African Americans, right? And so we're here when we're talking about Black men. And then I know we talked about earlier about a little bit about recruitment, Dr. Hill and his, and then we had some conversation in the Q&A around recruitment, but we have to do a better job. This is with the oversample of Black men, which is very disheartening to me. But I think I know what the problem is. Y'all want to hear the answer? Oh, okay. But I think I know what the problem is. So here's my take on what I think the problem is. I think the problem is simply this. Indeed, my colleagues at the National Center for Health Statistics, and they know this because I've given a talk a couple of years ago, so I'm not saying anything new to them. We oversample African Americans. We oversample race, we oversample income, but we don't oversample at the intersection of race and sex. And that's where things fall apart, right? That's where things fall apart. And I think we need to be more concerted and intentional when we think about, particularly when we're putting together studies and studies of this magnitude, because it's not clear to me what we can say about Black men, and we can only monitor so few when we think about these studies. Next slide. And so I did a similar thing with the Health Retirement Survey data here when I was thinking about these are the number of older Black men in the Health Retirement Survey since I think since 1998. And so as you can see, these numbers, they're better than what we saw on the actual NHANES data, but we still can do some improvement. Again, we're doing oversampling, but we're not doing the oversample for at the intersection of race and sex. Next slide, please. And here, I just wanted to share with you this. I'm working on a manuscript with some of my colleagues and a couple students. And this study spawned out of conversation with Dr. Hill and Dr. Whitfield one day. We were on a call and we asked the question, how many Black men are in cognition trials? And so we've done a scope and review, and between 2000 and 2020, and of the 265 studies that were eligible, of the 265 studies that we found, only 73 met our inclusion criteria, and we only found one study that reported the number of Black men in them. One study, and these are clinical trials. These are the trials, and remember we were talking about this earlier today. So we're talking about this. So it is so important for us to think about this impact policy, how important it's going to be. The funding that Dr. Hill talked about, that there's resources made around for you to think about recruitment. I always have said this, and I totally believe this. Recruitment is a local project that can then be taken best practices and potentially leverage globally, potentially. Next slide, please. All right, so the next approach is this importance of within group studies. Next slide. So I think this is very important, enough of doing disparities where we know there's differences on a number of health indicators. Particularly, it's well known, and Carl showed earlier in the Alzheimer's report, the state-of-the-art Alzheimer's report, that there are differences by race and ethnicity as it relates to Alzheimer's disease. So we should not, in my opinion, I don't think we should be focusing on documented difference anymore. We know that. I think documented differences now further stigmatize that population. If you want to advance science and move forward, I think you need to look within groups. You need to look within groups to think about studying and understanding how those, going back to the organizing framework, how those different levels of influence impact that group. Because if you want to reduce the gap, how about improving the health of the people who are doing bad? And then you should reduce the gap if you improve their health and well-being from that space. You know, that's the reframing that we need to think about when we think about doing these within group studies. Next slide, study, please. I just wanted to share with you real quick that I have taken that myself with a couple other scholars around the country. We've launched the Black Men Health Study, and we're currently in the field. Our goal is to recruit 5,000 men. We're using online surveying, and we're about 1,900 men short. So take down this website. Say if it's a Black man, you know, we're 18 and over we're in the field now. We're trying to get our goal of 5,000. Next slide, please. So this slide, this study is actually planned to be a longitudinal study. We're collecting baseline data now. One of the things that we wanted to do is that we want in the second round of data, we will start asking questions around ADRD and cognition. Next slide, please. And then one thing that's unique about the study is that we are asking about some of the key determinants that are known to Black men's health. And so we're using some of these things that we learned by talking to the Black men. When we designed our study, we actually talked to them and they helped in designing the actual survey in and of itself. We can talk more about that during the Q&A time. And so we have a number of these determinants that's on our survey that would afford us the opportunity to think about how these determinants that we are known to be stressors or coping mechanisms, how they impact the health and well-being of African-American men. Next slide, please. This is just some additional measures that we have for the study. We decided to look at masculinity, a masculinity scale, and what we're really excited about is we want to look at microaggressions. We want to understand how microaggressions operate. Next slide. All right, the next area I want to talk to you briefly about is this notion of employing quantitative and qualitative work mixed research. Next slide. So I think it's very important that I know at least in my training, when I got my degree, one of the things, qualitative research was not really highlighted. And I think whenever you have the opportunity to use qualitative research and or mixed methods, I think you should take advantage of it because it's important. These numbers that we get out of surveys are just numbers. I think that qualitative research adds some lived experiences around those numbers and it put things in context. And by the way, we're talking about Black men here today, but whatever group you study, it's very important for you to understand their historical context. Without understanding their historical context, you just running through an exercise to keep your brain sharp. That's all you're doing. That's a good thing to do because it keeps you sharp in light of the Alzheimer's, but you're not really getting the context. So I think it's really important for the context to be in this place, in this space. And so, I think they should often be used in tandem. I have a great appreciation for employing qualitative and mixed methods work. These lived experiences really, really drive home some of the things that we really want to know that we cannot know by adding a question on a questionnaire. There's so much you can do to it. There's only so much you can do on a questionnaire. So I ask, particularly those early career scholars, I'm talking to you, and even the undergraduate, I think about employing these types of methods in your research as you come up, because that's yet going to make gerontology even more sexy. So now I was gonna find a way to get it in. Next slide. Next slide. And so the other thing I wanted to talk about is this idea of employing a life course perspective. Next slide. I think it's important for us when we think about it, particularly with Black men, I think it's important for us to think about a life course perspective. The life course perspective allows us to do a number of things. And I know that Dr. Antonucci will talk some about this later on in the conference. So I'm going to just be very, very brief on it, but I just want to say this life course perspective affords us the opportunity to do a number of things. One is that it gives us the opportunity to think about assessing the impact of things while they're happening contemporarily. It forces us to do that. And it also forces us to think about the duration of key experiences over the life course, right? And so I think those are two things that I think are very important when we think about the life course. And next slide. And so when we think about a lot of the cohort studies that start at age 65, particularly when you think about Black men, that we miss the opportunity to understand Black men because most of them don't make it to 65. Newsflash, right? Most of them don't. We have the highest level of premature mortality among groups, race, sex groups. So starting at 65, we're already, overwhelming majority of Black men are already been excluded. Whether we're talking about a study on physical health or brain health, it's all the same. There's a selection of things. So I encourage people when they think about these studies to think about starting earlier in the life course, particularly as it relates to Black men. I applaud HRS for starting at 50, but I argue that we should probably start at 35 and move forward in life. And what this life course perspective allows you to do, watch this now when I pull it together. What this allows you to do, if you pull these things together, you get to think about using a life course perspective, using qualitative or mixed method research. You get to understand, you get to delve and get to understand what does it mean not to be Black or not to be male, but what does it mean to be Black and male and move through life and have these different experiences, right? How does structural racism actually impact and operate over time? And so the impact that you're studying largely for Black men, the duration of structural racism start typically at birth and you follow it over time, right? So the brothers in the room know what I'm talking about. So you follow it over time. And so I think these are the types of things, the opportunities we have before us to think about how to move forward when we're thinking about AD/RD work and the like. Next slide. This is just, I put this slide in here. This is just a resource that we have that I found that I think that focuses on life course influences and the impact of racism. So this is a really good resource to have when you're thinking about trying to understand life course perspective and the influence of racism across the life course. Next slide. So the last thing I really want to talk about is as it relates to, this 80 Black men brain health, is that we got to diversify the training force. We talked, Dr. Hill talked about this earlier in a way. We need to diversify our biomedical training force. And we need to do that by increasing the people of color in gerontology, people of color in AD/RD work. We need to do that. And there are a number of programs that are out. The Alzheimer's Association have some grant funding for early career faculty. The NIA has funding for early career faculty and undergraduates. So I think we need to certainly pour into our next generation of scholars so that they can carry on the torch. And I applaud the efforts of the organizers for the R13, this R13, when we're talking about a number of these things. And just to be in full transparency, I didn't look at the agenda until after my slides were made. So the fact that I had these things and they were going to talk about it says that we were already in lockstep, and it's the importance, because I have colleagues and other eminent scholars that's going to delve deeper into this throughout the conference. I think this is nothing more important than to making sure we got the next group of people behind us that can carry this on. I don't know about Dr. Hill, but I don't plan on doing this forever. So I want to make sure when I walk away from it, in Macon, Georgia, we have a saying, when you need to leave the place better than you found it. And so that's what my goal is. And in doing so, I think we have to engage our early career faculty, our early career scholars, I'm sorry. And then the second thing is that we want to increase the training. And we talked about this also, of translating evidence-based work into solutions. It's not enough for me to write a gazillion papers. All that is not worth it if I haven't made an impact, right? Because those papers, really, most academicians in the room will tell you, those papers, people who really need it can't get to it. They charge you what, $40, $50 for a paper? We get to it because we happen to be at a place that pays that cost for us. But and the people who really need it, we want to be able to make sure we get that information to them, particularly on a population and an area as Black men brain health, particularly as important as that is. I think it's very important for us to be solution oriented in the work that we do and disseminate it in appropriate format to the appropriate people. Then the other thing is, this is my favorite one. Increase the community involvement and training and how to approach the community. I'm gonna say that one more time because this is my favorite. Increase the community involvement and training on how to approach the community. Because most of the time, folks going to the community don't know how to do it. They run into the community. They don't engage in these CBPR principles that Dr. Hill talked about earlier. They don't do that. And the other thing I think is going to be important when we're talking about engaging these communities to do ADRD work, we need to listen to them. They know their community. We need to listen and we need to understand what it is that how we can gain an entree. We need to develop trust. And just newsflash, we might know what we know from our training, but we don't know that community. All right. We might know what we know from that training, but we don't know that community, and we need to learn that community. And if we want to help the people in that community that look like us, we have to stop, and we have to. Many of us have to check our egos in our cars, and then go to that community, right, and engage, and then sit down and have a conversation so we can move forward, and we can get Black men in these studies so that when we generalize the results, we're confident that the results that they're talking about, they're talking about me. Because right now, I don't know when they talk about these results, I don't know if they're really talking about me because I don't know how many people, I don't know how many Black men in there, or it's so small that we can't make meaningful decisions behind. And then the last one is to have community members become a part of faculty and engage courses on community involvement, particularly as it relates to aging. So how about this bright eye idea? And I think they do it. I know it's been done at UCLA. Have community members come in and teach courses about community. That's a radical idea, isn't it? No, it's not. It's not. It's just that we need to do it. It's been around for a while. How would we think about it? Have somebody from the community who I just told you who better know about a community than the community, right? And if you've been to one community in the United States, you've been to one community in the United States, right? How you recruit is local. How you recruit in Macon, Georgia, probably different how you recruit in LA. So we want to be mindful of that. And we want to learn together, because this idea around ADRD and can we take it and can we improve Black men brain health? I think we can, but I think it's going to be all of us working together and working across different disciplines and having an interdisciplinary team to do that. Next slide, please. These are just some funding announcements we have. This is for early career faculty, early career scholars. If you're interested, please feel free to email me and I can give you the information on these different funding opportunities that we have at our RICMAR. Next slide, please. So I just want to conclude before we go to Q&A, and I looked at some of the faces, so I know we'll have a good time in Q&A. And so I think where we are in the space with Black men's health and Black men brain health, we're in a very unique space and a very exciting time. We're at its nascent stages, and we get to develop it how we want to develop it. How about taking some of the opportunities and develop it in a way and start thinking outside of the box and learning and thinking about doing things in a way in which it reduces, starts to dismantle these different levels of racism and start building and engaging trust and get the brothers in the studies that we need to get the help that we need. It's going to require an interdisciplinary team. And I think I just discussed some of the approaches that we need to engage in to go beyond the status quo that we have today. And then this creation of this structural discrimination measure that I talked about, I think it's an exciting time. I think it would be helpful and we can learn from it. And then using this life course perspective to include a lived experience is going to be really, really exciting and moving forward around Black men brain health and Black men's health. Next slide, please. I couldn't have done this by myself. I just have a smattering of people, and this isn't an exhaustive list. I have a smattering of people who have helped inform my thinking, who helps and challenge me every day to make me be the best person I can. And this is just a smattering of people. But I do want to, of this list, I do want to acknowledge all of my undergraduates, all of my doctoral students, and all of my postdocs who helped me move along this way. Next slide, please. And those are just some fun. These are just the people who have helped me keep the funding going, and I really am truly appreciative of them. Next slide. And I never like to close a presentation without a quote from a Black author, a Black male author, in fact. And I thought this one would be appropriate for this one. And I have a number of them. So don't ask me what they are. Come to the next talk and you'll see a different one. All right. So this is the one that I want to share with you today. And I think it's appropriate, by James Baldwin. Not everything that is faced can be changed, but nothing can be changed until it's faced. Thank you. Oh yeah, I know they look for that.
Thank you, thank you. So you can see why he is making a big, big difference, not only in the academy, but also in the community. So at this time, we're going to do Q&A. So we know we have lots on your mind, comments, questions, and Kalpana will be going around and taking those questions.
Thank you for that great presentation. One of my questions is in terms of engaging the communities. I haven't had the chance to start doing that yet, but one of the things I hear is that community organizations or community constituents don't want to invite people doing research in because they take the research or they take the data and leave and they don't get anything in return. So how would you go about helping communities figure out a way to retain some autonomy, some control over the things that are being said or done about their communities?
So thank you for the question. That's a great question. The first thing is you got to build a relationship, right? So what I've always said and what I truly believe in, if you're going into a community, I think you need to be in my opinion, you need to have been in that community at least a year before you talk about going up in there running and getting some data analysis. That's just my take on it. Others may have a different opinion because it takes time to build a relationship, right? They need to understand that you're there with them and not there just to get in what we call helicopter researchers, go in, get research and get out and give nothing back. I think that's one of the biggest problems we have. And a lot of it is that because people have done this before and the communities are so afraid of what you're going to do or what we're going to do next. So I say build a relationship and you go think about who are the key stakeholders, have conversations, learn what they think of as a problem. Because you know what? A lot of time what we think the problem is, they don't even want to talk about it. That's far from it. They have other issues. And then you need to be truthful and honest and transparent, right? So when things come up, or if you're thinking about writing a grant, or you're just thinking about doing stuff, you need to be clear with them what the outcomes are up front. And when things change, you need to be transparent and let them know it's changed and how that change is going to impact outcomes. I think that's important. It's really, really important. And to keep open lines of communication. And when afforded the opportunity, you should do some town hall types of meetings with them, or some meeting where people from the community can come in and ask questions of you, right? And the other thing you don't want to do, you don't run up in the community, you don't want to run up in there like this, because this say so Johns Hopkins, right? This doesn't say, you want to go and you want to say we're in this together, right? And we're in this together and we're going to work together to solve some of the problems. And whatever problem you can solve, you need to let them know. Don't say, oh, we can do it, and you can't do it. Because you're setting yourself up for failure, and you're creating instant strife in the relationship up front.
How you doing? My name is Craig Cook Sullivan. I'm from San Francisco, UC Davis Good Life program. My question is, as a barber in the community for the last 26 years, how can we umbrella this and like you say, we start from the local, from the ground in the local communities. How can we make this attractive to other barbershops or community businesses that deal with the people directly who won't seek help, but come to our businesses and seek that same help from us? How can we grow, or what kind of support can we get to open this ground?
So okay. So that's a very good question. I think one of the things that I've seen done is that where there have been a number of projects that have done within the barbershop initially, and then from there they scaled the project up and took it outside of the barbershop and building relationships beyond your barbershop with the other community organizations, and starting to engage and create. If you haven't done this, one idea, maybe you want to create some organization or meet with other community stakeholders and then say, hey, here's what I'm doing, share with people what you're doing, and share with people how it's impacted those individuals so the men or the women that are coming and getting their haircut, share with them how it's impacted. Because you have a really good position, because people sit in that chair, they talk to you about a whole bunch of stuff they won't even talk to their doctor about. Right. And so you have a whole different, vantage point. But thinking about the other thing I can think about, I think Carl mentioned this earlier, if there's some way to partner with a social worker, right? Because there's a lot of times I can imagine the stuff you're hearing, some of these things are about services and connected services, and thinking about linking those things up, as well as engaging the other business partner. Because, you bring up a good point. This is not, when I think about health, I think about health or brain health more globally and across different sectors. And oftentimes we have not thought about different sectors beyond health. We haven't thought about how businesses can impact the health, right? By providing services that some people may or may not have access to. So I think that's the place I would start.
In line with that question, we received one from one of our virtual attendees. As a descendant of preachers, have you ever built longitudinal research or clinical health cohorts of Black males around churches? If yes, what worked well or not so well? And if not, are there secular connections? Are secular connections a better entryway for the community?
So I have not built cohort around Black men in churches, but I do have a colleague that Dr. Marino Bruce, that is thinking about building a cohort around Black men in churches. So yes, that's on the horizon.
Yes, sir. Thank you for an excellent presentation. And, I'm happy that question came up, because I was just in Detroit, and the Black church has always played a major role in any driving force that we've been able to accomplish. So my pastor is doing a series on it right now. But Pastor Kenneth Flowers in Detroit, at one of the biggest churches there, he's actually doing a Black Men's Health Awareness Day in the coming weeks on the Saturday before church service. But I was really moved by that, because whether it's been Africa and HIV/AIDS or here in the United States, I don't partner with somebody if the faith base is not at the center of it, because I'm not going to waste my time. I realize if God isn't at the center of it, it's not going to work. But that's why I'm happy you touch on the role of the Black church, that question that came up in the barbershop. But the other thing is, I want to give kudos to USC as well. For having this conference. I'm a USC alum, but they did something that moved my heart in June. They have the Family Caregiver Center, and they did something, which I've been a caregiver, my mama and uncle, but the role of caregivers, and particularly African-American male role caregivers. So nobody ever talks about that point, but the Alzheimer's Association mentioned to me early on about the death of caregivers because the stress we're under. So I know, I lived through it. So I just wanted to see if there's other family caregiver centers if you interacted with. But like I said, I know USC is doing some powerful stuff to their family caregiver center. Thank you.
So thank you so much for your comment. I have not interacted with other family caregiver centers, but I do know there are other family caregiver centers that do exist, but I haven't done that. But I do think caregiving is very important. It's very, very important. And I think it's almost as invisible as the population of Black men. And I think it's important. And I champion those people who study that and those people who are in that space to continue to fight the good fight, to bring it forward and the heightened awareness of that. Yep.
Hi, thank you for your presentation. I just want to say this is extremely exciting and very validating for myself. As I stated before, I worked for UC Davis, but during the pandemic, we started the Good Life program for healthy aging. And it was one of those things where I saw an opportunity to pour into the community because we could not conduct studies because we could not see anybody in person. So here we have opportunity to create programs where it was more of a public health service, but being able to convince institutions and executives sometimes is really challenging because they don't see that vision and they didn't quite understand the concept of just giving back to the community with asking very little in return to build that trust. So this is probably just more of a statement. Like I said, I really appreciate your presentation because it's really showing me that this is the right path and it's very possible. And these are the things that we should be doing for our communities, just putting that energy into structuring trust and an openness, open conversations, and going into the communities and showing them that we do care, because we'll never get them to enter into research otherwise. So thank you so much.
Thank you. And I like that name, The Good Life. That's dope. I like that. Thanks.
Hello, thank you for the work that you're doing. I think it's extremely inspiring. My name is Latoya Stevenson. I'm a licensed clinical social worker from Florida.
I can barely hear you.
I'm soft-spoken, I'm sorry. My name is Latoya Stevenson. I'm a licensed clinical social worker from Florida. I wanted to say that the work that you are doing is extremely inspiring. One of the most rewarding experiences that I've had in my practice is being able to facilitate a group specifically for Black men related to mental health. I don't think that Black men don't want to engage in these opportunities. I think that there's a lack of opportunities for Black men. And as mentioned earlier, I think that it's pertinent for professionals to be going to the places where Black men are, going within the community to provide these opportunities. But I do have a question for you. My question is about the research on structural discrimination and what that project would look like and how you would go about facilitating that and kind of getting that research within the community.
Yeah, so great question. So, and thank you for the question. I totally agree with your comments. So what we've started to do now is we're starting, we had a doctoral student who worked with us on the first phase of the project, in which we actually went and we had some focus group discussions around with older African Americans in Baltimore City to start thinking about how, when they hear the word discrimination, what do they mean, right? So that we have discrimination measures already in this out in the literature. But I think one of the things that can be improved upon those measures is that I think when you ask somebody, do you feel unfair treated because somebody took a long time for them to come wait on you? I think that's totally different if you had dogs sitting on you and you had water hoses turned on you. I think your responses would be different, right? And thinking about that from an aging experience and with an aging lens or life course lens, I think we want to think about how those questions could be more relevant. And so that's one of the ways in which we're thinking about doing it. And we've been engaging the community. We're talking to people in the community as we're thinking about putting together this measure. So the community voice, particularly as it relates for older African Americans, are center in this approach where we are now. So thank you for the question. See, that's what I'm talking about. Somebody keeping me right in check. Basically, she's like, Roland, you talking about this. What is it that you're doing? I appreciate it. I appreciate it. Yes.
Oh yeah, Dr.
Okay.
Thorpe, question for you. What incentives have you used in trying to recruit Black men to participate in your research?
Yeah, so financial incentives, you do the survey, I think it's a $20 gift card. The $20 gift card. The other part of what we learned with recruitment around Black men, so this was part early on when we were developing the survey, before we started developing the survey, we also talked to Black men in different areas of the country and across different age groups to find out how they would like to receive messages around health, what avenue did they want to receive those, what mode did they want to receive those messages. And we shared with them photos of what would draw, if we had a website, what would draw you to that website. And so we got all this information And we did exactly what they said. They want something, they want a website. When they click on it, if they see themselves there, right? And so we did that. And we did there's some, we listened to them throughout our process of developing this survey, and we talked about the words of using different words and how important it was for them. So a lot of them had buy-in. And then what we did ask them to do, some of them in there, we said, now you got buy-in. When we send this link to you, we want you to be a champion for us. And that has worked for us. And just continuously being honest and being open with them, right? And so I think that has been very, very helpful. No one has, we were nervous about, was $20 the right amount of money? And then, for those of you in academia, you can't go so far. The IRB is going to tell you that ain't right. You need to dial it back. So we were really worried about it. And a lot of what we found out is that it wasn't even about the $20 for them. It's about somebody wants to listen to me. And then we told them what the outcome would be, and just being able to sit and talk to them, some of them, and to be able to engage them online. Yes.
Hi, Julie Flieger. I'm president and CEO of Project Sleep. And I love what you talked about towards the end about including the community. I think sort of like at all phases of research, the community will help you come up with solutions. So I come from like the patient perspective space, where often I'm going to medical conferences and there's no patients that are ever speaking at the conference. And you kind of wonder, how did patients get left out of the conversation? We have voices, the same way you talk about the community. Do you think of any sort of like system level solutions? Because to that problem, one of the ideas in the patient community is that one like prominent speaker at conferences said that he wouldn't speak unless there was a patient speaker included at the conference. Call it the patient included. So your conference had to have a patient included before he would be willing to speak. It hasn't really taken off as much as I'd like, but I love that concept. And I was just wondering if there are any concepts like that to make sure that the community are included.
So thank you so much for your question. I think you raise a very good point. I don't think that I'm aware of any conference that I've spoken in the last 5 years that I was in a space and there wasn't a community voice represented. For me in the places that I've been speaking, I guess people are asking me to talk, and there's this understanding. The group, the conference, the organizers of the conferences have the same. We are on the same sheet of music about community and voice. So I've never had to engage in that, right? And I think many of us in the room that do this work, we put community first, right? And I think if you put community first, then their voices should come out and their voices should be heard. I think I've never had to impose on someone. So I'm not going to come unless the community, but because most of us in the room now are, we're of the community, for the community, and by the community. When I say by, we stand with. Prepositions are important, Dean Bird. So if I got to just do this. I got to do this. Listen, I want to talk to the fellows for a minute. If you're not going to the doctor, take to the doctor and get you a doctor. Part of why we are where we are now is because we don't even want to go to the doctor. Now I know the system that Roland, the system is not for us, blah, blah, blah. I get that. But you know what though? Let me tell you a little secret, what I learned. And I looked around, and my father was an example of this. He gave me that, God rest his soul. He gave me that. When I go to the doctor, he was a retired engineer, federal employee, had to have an annual exam every year. When he retired, he stopped getting his annual exam. And 10 years later, he passed. And when I talked to him one day, because you know, from the country, you can't never tell your parents anything because you always little boy, right? So I asked him why he didn't go to the doctor. He said, because the system is, I don't want to go to the system. It's not set for me. They don't talk to me the right way. Okay, I totally understand that. But what I've learned though, brothers, don't go and you be in the ground and that system's still gonna be there. So go and extend your life and do, if you're not doing it for you, do it for somebody in your family. If you got a daughter, say you're gonna walk her down the aisle, make sure you can walk her down the aisle to give her away, right? You need to do these things. And that's my quick plea, because I know there are a couple more questions. Take yo to the doctor. That's my quick plea. And the reason why I say take yourself to the doctor, because all of the preventive things that we think about are tightly linked to brain health. They're tightly linked to brain health, cardiovascular disease, engaging in exercise, eating right. All these are tightly linked to brain health. There was a question.
Yes, sir. Hello. Hello, everybody. My name is Michael Tapman. I'm also part of the UC Davis Good Life program. And I had a couple of questions for you, specifically for you. So maybe we can get some answers. Where can we find older men? Where do older men hang out? Like, that's one of the questions. Another question is, where do you work out? Work out anywhere? My third question is, how can we get more women to promote men health? Men listen to women, so if women putting it out there enough, then it'll register in our head. So,
okay. All right. So if I don't remember all of them, do come back and ask. So it's interesting that I'm gonna start with the one with women first. It's interesting you make that comment, and I've learned this when talking to men is that you're right. If you and that's a crucial key point when recruiting men. Women out recruit men for Black men. It's just simply put. There are a number of different reasons. We don't have time to go to them. We maybe can eat lunch together. We can talk about some of those. But yes, women. But this is the approach with women and talking about going to the doctor and engaging the healthcare system, right? So you want to make sure it's framed in a nice way and positive way. And I think that's helpful. What I've also noticed when we're talking about Black men, a lot of the Black men, they didn't want their wives to go to the doctor with them. Because you already know, then they gonna know what the doctor said. So they can't have that trend, they can't have that interpretation time frame from the doctor office till I get home. Oh, honey, what did the doctor say? Oh, he said everything was good, baby. What we eat for dinner? When you know that one, what the doctor said, you know you got a long list of stuff. So they don't want that. But what they did learn in the process that they would love for their daughters to go. So I think there's this thing. I don't know why the daughter over the wife, because the daughter's typically gonna tell the wife anyway, or the wife gonna pressure the daughter to tell them anyway, the information's gonna get back. So that's one of the things. The other thing is, I work out at a gym that's less than a mile from my house. It's funny, Dr. Hill and I were talking about this, I think yesterday, about it. I used to run outside a lot, and then 2020 hit. I used to run early in the morning, and I can no longer run early in the morning because I don't want to be mistaken and end up on the ground. Right. So then I have to change how I think about when I go run and all those things. But I do, it's a gym at my house. I do a lot of rowing now and getting back into running after a serious injury. And the first one, where do I find old men at? Oh, yeah, it's easy for me. I find old men at one, you find them at the barbershop because they ain't gonna cut their own hair. Because that's one, you find them at the barbershop. And if there's a car garage still going on, they're hanging around the car garage, right? Yeah, you're laughing, but that's where they hang out, right? And then you're gonna find them, watch this, in church on Sunday. That's where you're gonna find them in church on Sunday. Because we have this law, we go to church, we raise in the church, then we fall out, then we have a teachable moment, then we come back to the church. But we find most of them. And then also the other places that you can find them at health clubs and things like that. So I don't think that they're really hard to find. I'd rather she ask the question because you got three, and that's kind of fair.
Yes.
I'm sorry.
Got one last one here. I'm right behind you.
Hey, thank you. Real quick, I know you said for Black men, take your butts to the doctors.
No, I said take your paws, and you said butts.
But
because I would use another word though. But go ahead.
But what I'm looking at and what I'm trying to see is there's generational, right? What are we doing to teach the young kids about going to the doctors so they're not afraid to go to the doctor, so that it becomes a habit? It seems like we're focusing, and rightfully so, on the ones who are older now, but it's going to only change with the generation when they see it as it's a new habit, and then they're going to teach their kids how to go to the doctors and that it's okay. We know that there's going to be systematic racism, that the insurance, it's a scary place. I'm an adult. It's scary going there. You don't know what bill is going to come out. But we got to start teaching the young people that this is the place that you need to go. And so what are you doing in that sense to that? And I think I had something else. Oh, and then just with the workouts, we need to see more people in their 50s, Black men working out, not necessarily be bodybuilders, but just the average person. You talk about your health, I could talk about my knees. You know, these are some of the things we're dealing with. We gotta show people that you don't have to be perfect. You don't have to be an ex-football player. You don't have to be a superstar. You have to be an average person who's, like you said, is looking out for, you know, his wife, or looking out for, want to walk his daughter down the aisle. They need to see more of that. So 2 questions. What are you doing to show for the younger generation and the older generation?
So I think you raised, thank you. I've at a number of places, at some other conferences, I've had a conversation where it's been set up where we just, the group of men sat around and talked, and we talked about those very things. We have real conversation about, are you going to the doctor, right? Are you not going to the doctor? And then what role model is that setting for your son? If you don't have a son, if you have a nephew or family members, because I do think it's important for you, and I think it's liberating. You know, I know, Tom Joyner had take someone to the doctor day, this national campaign. I think it's liberating to think about or to see a Black boy and his father going into the doctor's office. You know what I want to see before I close my eyes on this side, on the transition? I want to be in the doctor's office one day, and I see them go in the doctor together, and they both have physical exam, and they come out, right? And then having a conversation around that, socializing that on the way home, right? Socialize. So, what does your numbers mean? There's one of the things that I've done for is the Know Your Numbers campaign, the key numbers, right? Blood pressure, A1C, and waist circumference, and cholesterol. So thinking about that, having a campaign around that, heightened awareness around that are some of the things I think that can occur. And I've done some of that before. And the group I've done it with before, I think it turned out in a positive way. And you had the second question. Yeah. Okay. Yeah. Thanks.
Thank you. Thank you. Definitely a treasure to the field. Let's thank Dr. Thorpe.